Healthcare is currently adopting artificial intelligence 2.2 times faster than the broader economy. Predictive algorithms are being integrated into clinical dashboards to triage patients, flag risks, and accelerate decision-making. This line graph illustrates a severe paradox in that rapid deployment. When AI assistance is introduced into clinical workflows, diagnostic accuracy doesn't improve. It plunges by 11.3 percentage points compared to clinicians working entirely alone. This updated plot shows the introduction of explainable AI, systems designed to show clinicians exactly how the model reached its conclusion. Even with total transparency, the accuracy remains completely flat at that lower threshold. Clinicians simply defer to the machine's output, even when it conflicts with their own correct judgment. These systems are not supporting clinical expertise. They are forcefully codifying historical human errors into machine-level certainty, creating an automation bias that degrades the quality of care. When machine learning engineers detect bias, the standard reflex is to balance the training data. The assumption is that equalizing the demographic distribution to a strict 50-50 split will automatically yield an equitable model. This split-screen visualization compares a perfectly balanced dataset with its actual diagnostic output across 16 independent cardiac machine learning experiments. Despite a perfect 50-50 male-to-female data split, these algorithms systematically missed disease in female patients at a rate up to 17.8 percentage points higher. Looking at liver disease prediction models on this updated chart, the phenomenon repeats. With identically balanced datasets, the false negative disparity spikes to 21% for random forest classifiers and over 24% for logistic regression. Dataset balancing is a mathematical patch applied to a biological problem. If the clinical labels and diagnostic thresholds in the training data were originally calibrated to male physiology, numeric parity does not equal epistemic equity. A 2024 study titled Slicing Through Bias examined advanced models trained on major public chest X-ray datasets. Researchers found these models consistently missed pneumothorax in female patients, even when the training sets were balanced. The models bypassed the lung tissue entirely. Instead, they learned to detect external hardware like chest drains and ECG wires. This is shortcut learning. The model assigned a 99% weight to these artifacts and only 32% to actual biological pathology. This tracks directly with clinical reality. Historically, men receive more of these specific invasive interventions. The algorithm simply calculated a mathematical correlation between the presence of a tube and the severity of the disease. The consequence is immediate and dangerous. A sick female patient presenting without a chest drain is automatically misclassified as healthy by the algorithm. The AI learned nothing about biological pathology. It perfectly memorized the biased practice of care. This failure extends from image recognition into tabular clinical algorithms. Consider the MELD score, the standard metric prioritizing patients for life-saving liver transplants. The MELD score uses serum creatinine, a byproduct of muscle breakdown, to measure kidney failure. Women naturally have lower muscle mass, producing less creatinine. For the exact same level of critical organ failure, the male receives a high priority score of 22, the female a lower priority 15. When an algorithm applies a uniform, male-calibrated reference standard across both sexes, it mathematically locks historical inequities into modern medical infrastructure.
Modern foundation models, like Delphi 2M, are trained by ingesting vast amounts of longitudinal electronic health record data and ICD-10 billing codes. Take endometriosis. Patients typically wait 7 years across multiple providers, their records filling with incorrect codes like anxiety. When surgical confirmation finally occurs at year 7, the true diagnosis is appended. The previous erroneous codes are never deleted, remaining as ground truth. When an AI interprets this timeline, it learns that endometriosis is a rare, late-stage disease. The model becomes entirely blind to the early biological signals because the data maps human error, not pathology. This creates a severe data density gap. Large registries contain tens of thousands of recorded cases for conditions like diabetes, but only a fraction for endometriosis, even though they affect a similar percentage of the adult female population. Longitudinal EHR data rarely describes the biological reality of disease. It is a record of the healthcare system's delays and prejudices. To fix sparse datasets, machine learning engineers frequently turn to synthetic data augmentation, generating artificial patient records to patch the gaps. The data gap starts in foundational research. For decades, preclinical baselines relied overwhelmingly on male animals and male cell lines to avoid hormonal variability. Synthetic generation has a fundamental limitation. It only interpolates within known distributions, creating more variations of the same male default biological baseline. It cannot extrapolate unknown unknowns. An algorithm cannot hallucinate unmeasured female pharmacokinetics or simulate how the menstrual cycle alters immune responses. You cannot synthetically generate what medicine never bothered to measure. Blindly relying on it creates a dangerous illusion of completeness. This limitation heavily impacts large language models like GPT-4o and Claude when tested on triage decisions. Developers use alignment training to ensure these systems produce fair and ethical outputs. But there is a strict divide between linguistic empathy and epistemic empathy. Linguistic empathy allows a model to structure its sentences using ethical, professional terminology. Epistemic empathy requires the underlying data to reason accurately about unrecorded realities. When researchers evaluate aligned models in clinical scenarios, the outputs sound highly professional, yet they actively diverge from clinical equity because the models lack the specific physiological knowledge required to accurately assess female patients. Fine-tuning models to mimic professional language does not fix epistemic bias, it just hides it better. The solution requires that we abandon static ICD billing codes as our core ground truth. We must re-architect the training features from the ground up. This means integrating computable clinical rules, dynamic diagnostic thresholds that automatically adjust their math based on a patient's sex and specific life stage. The tensors feeding these models must encode new parameters. Variables like the menstrual cycle, a patient's pregnancy status, and their menopause transitions. These critical metrics can no longer be ignored or treated as binary checkboxes. They must be logged as time-varying, continuous parameters. Female biology provides distinct natural segments and hormonal transitions. This makes it an ideal environment for time series machine learning algorithms to map patterns and extract systemic risk signals over a patient's lifespan. The next wave of precision medical AI won't come from hyperparameter tuning or synthetic data patches. It requires rebuilding the epistemic foundation to reflect the full dynamic spectrum of human biology.